Hello? Hello, Mehmet, are you there?
Yes, I'm here. How are you?
Okay, how are you? Fine, how are you doing?
Good to see you.
Happy to see you again.
Everything is fine.
Yeah, okay. How do you think we have to manage? Do you want to make an introduction or anything like that, or just a comment after the presentation?
Yeah, probably we can manage the questions.
Okay.
It will be nicer.
I prepared just 2 or 3 questions I can share with you. One is about the opportunity and the difference between performing just decompression or decompression plus duroplasty, which is the opinion of the speaker. Second one, it's about opening or not the arachnoidal layer, which is different from the first one.
Right.
And finally, maybe more general, would you treat Chiari 1 without syringomyelia, and in which case and with which symptoms? I mean, is there an indication for Chiari 1 without syringomyelia? These are my 3 questions. I don't know, what were you thinking about?
Actually, there are many questions coming from participants, especially. So
we can leave them
have
speak
to
about it.
also forward those questions to the speaker.
Okay.
Only Massimiliano is here.
Hello, everybody.
Hi, how are you?
Ciao,
Welcome.
Massimiliano.
Thank you.
Good to see you.
Ciao, Massimiliano.
Ciao, ciao.
Ciao.
Buongiorno.
Ma c'hai attorno un aureola? Ah, è un arco.
Sì, è un arco. What about the weather in your nations, in your states? Everything is doing well? No.
Yeah. In
rain?
Turkey, it's quite well.
Yeah.
It's quite a hot weather. How is it in Italy?
The same.
It's hot.
Summertime.
Right. Good.
About the COVID. What about COVID in your countries?
Currently, we are having somewhat increase in the numbers.
I see.
Although we had decreased, we are afraid of having a second peak. I wish we will not.
But are you having
Hello,
increase?
Hi,
Are you
Atul.
having increase in the positive people, or also
Positive
increase,
people, right?
or also increase in the really ill people? Because in Italy we have no longer really ill people. You don't have the disease. You have positive people, but you have not the disease any longer.
Right. The number of daily deaths is about 15 to 20, but the positive cases is about 1,200, 1,300 a day.
Okay. There is Goel who's asking you to unmute him.
Did he come?
Yes, he's asking you to
Good.
unmute him.
Atul, please unmute yourself. Good.
Yes, yes.
Nice to see you.
Mehmet.
How are you?
Massimiliano.
Hi.
Hi.
How are
Nice
you?
to see you.
Fine, thank you.
You look very fresh and fit.
Apparently.
Atul, you know what? I am in the boat.
Really? Show me the water. Open the window, Mehmet. Show the water.
Yeah, I did. I did. Yes. Yes.
Dr. Solanki is there? Girish? MEHMET? MEHMET?
Hi, how are you? I hear you.
MEHMET, Girish is there? Solanki, Dr. Solanki?
Gurish did not come yet.
Okay.
I sent an email, another email recently. I guess he will do it.
Okay. Max,
Yeah.
what are you up to, my friend? Everything okay with you?
Pardon me, say again.
Everything is okay with you?
Yeah, thank you. Thank you so much. Now we are starting the summertime, and people is very happy because they start to get out their homes and enjoy life, restaurants, the sea, the beach, even if with some restrictions, we have to use the mask every time we get in a public store. Our work is becoming quite normal with the same operation rate of before COVID pandemic, and apparently everything is going better than 3 months ago. Nevertheless, we have to pay attention according to MEHMET opinion, because we are not completely out. In Milan, where Maurizio Fornari works, there are some more cases of infected people, even if with a less aggressive form of disease. So we hope that everything will conclude as soon as possible, and never surrender, because the risk is close to us. We have to unmask it.
I think we should start the meeting. Although Gurish did not come yet, we will moderate the session with Dr. Maurizio Fornari. The first speaker will be Massimiliano Visocci from Italy. He will talk on the current management plans for Chiari Malformation. Please share your screen.
Gulrich is here, ZILEL.
Okay.
Gulrich is here.
Okay, good. Very nice.
I'm trying to share the screen, but host disabled participant screen sharing says.
So you have to make him co-host.
Imat is co-host.
No, you have to make the speaker co-host as well.
Host disabled participant screen sharing says.
Yes. Now you can share.
You see?
Yeah. Please try to share again.
Do you see my presentation?
Not yet.
Not yet.
At the bottom there is share screen green button.
Yes, I push it, but let me see.
At the bottom of the screen.
Yes. Do you look? Do you see my?
I think yes.
Yes. Do you
yes,
see?
It is.
Perfect. So Mehmet, please tell me when I can start.
Yeah, now you can start.
Okay.
Yeah.
Thank you.
That's
Thank
fine.
you, Mehmet. I'm so grateful to your opportunity as chairman of the Spine Committee. You accepted our proposal to share with your organization as a Neurorehabilitation Reconstructive Committee this good opportunity. I really thanks also Atul as president of the Craniovertebral Junction and Spine Society to allow me and all our friends to attend this beautiful presentation. This beautiful meeting. This meeting starts from a long time ago with our friends meeting everywhere all over the world with MEHMET, with Atul during the Craniovertebral Junction and Spine Congress and meetings. And this presentation they continue a trend start a couple of weeks ago with a similar but different meeting during the COVID pandemic. My presentation, the title of my presentation deals with surgery of Chiari malformation. And what I'm going to present comes from the updated literature and also by my personal experience on these very challenging and difficult topics dealing with craniovertebral junction spine neurosurgery. First of all, just to remember, to refresh what for me is always difficult to remember, the new classification of Chiari malformation. We have too many different types of denomination of different clinical status. Many years ago, we had only Chiari 1 and Chiari 2, then Chiari 3, Chiari 4. Right now, we have Chiari 0, which is a non-Chiari, a non-syringomelia condition, but with a crowded posterior fossa. And we have also 0.5 Chiari, which is syringomelia standing alone. We have also type 1, the well-known Chiari condition, which is a complete or partial herniation of cerebellar tonsil at least 3 or 5 millimeters below the foramen magnum. Type 1.5 is the same of 1, but with odontoid retroversion and without spinal dystrophism. Type 2 is a more consistent herniation of tonsils, vermis, pons, with spinal dystrophism and hydrocephalus. Then we have type 3, which is an occipital cervical hernia, and type 4, aplasia or hypoplasia of cerebellum. So we have once again to remember which is the Goel paradigm. Goel states and always confirm, also in the last webinar of a couple of weeks ago, that Chiari malformation doesn't exist. In other words, it exists Chiari formation. And Chiari formation is the consequence of some etiological, very special feature. Very simply, the most known type of Chiari are type 1 for general young adult people, and type 2 for generally childhood patient. Type 1 less severe, type 2 more severe. Type 2 is associated with many others conditions like hydrocephalus or also tether cord and myelomeningocele and etc. This is an example of an impressive, awful Chiari 3 malformation. Fortunately, we have not so many opportunity to meet in our career some monsters like that. Etiology for Chiari are small posterior fossa, hydrocephalus, craniosynostosis, abnormalities of the upper cervical spine. I must remember basilar invagination along with Kippel file occipitalization and the C1, C2 instability, which is a specific topic of Atul. And finally, arachnoid fibrosis around the tonsil. But first of all, the posterior cranial fossa crowded, so-called crowded posterior cranial fossa is the primum mobens of Chiari malformation. And this observation drives the way to perform posterior fossa decompression according to the special malformation of the cranial fossa. That means that the decompression should be more according to the craniocaudal extension of the malformation. This malformation counteract also the normal CSF dynamics. As we can appreciate on the left panel, we have a turbulence, meaning that there is a reduction of CSF flow spaces. So the flow has to increase in velocity as a consequence of a decrease of the absolute value. And this is another important observation. Let's start with the core topics. Who we have to operate? Patient symptomatic. When? As soon as possible. Sometime in pediatric, in childhood, it must be preventing more than curative. And how? With bone decompression, anterior, posterior, when dealing with settings, huge decompression with duroplastic, and we will see. But surgical indication is all comes from a clinical indication. Don't forget neuropsychological function as driving indication for Chiari, which is a Cinderella clinical components. Suboccipital craniectomy. We consider suboccipital craniectomy a less invasive surgical approach when we perform bone removal along with sparing of the dura or just dura delamination. Dura delamination is a way to enlarge the capability of elastic compliance dura without performing a duroplasty. Also, Catholic University, the place where I work in, has a huge experience in a pediatric transverse micro incision of the outer layer of the dura mother as an important alternative treatment to duroplasty. Number two, we have craniectomy and durotomy with arachnoid preservation. Very strange, but also interesting aspect of a surgical armamentarium. In this book, including many experience of my friends and the very expert craniovertebral junction surgery, we have this experience of Professor Spallone, to which I co-worked, with durotomy with arachnoid preservation without closing or suturing dura mother. What happened? Good earning of posterior cranial fossa space, but also CSF leak, which with time tends to absorb spontaneously. A third type of surgical strategy is craniectomy and dural patch. We all know that dural patch can be autologous, like pericranium fascia lata, or heterologous, like cadaveric dura, or synthetic, like Gorotex. Then we have another chance, which is craniectomy, tonsils coagulation, arachnoid debridements, obex opening, and dural patch. When we have to propose this strategy, when we deal with intradural membranes, veils, pouch removal is important to rehabilitate the posterior cranial fossa CSF space deteriorated and compromised by infection, arachnoiditis, malformation, and similar condition, all with duroplasty. And we also know that this strategy is very effective in the Chiari malformation associated with the syringomyelia, more likely type 2 Chiari malformation. But what strikes our soul is that we have an improvement no more than 50%, both for syrinx, both for Chiari symptom. That means that this is not an 100% effective surgical strategy. You know, every schools, every groups develop different way to deal with craniectomy and opening of the dura and arachnoid debridements and manipulation. And I think that most important thing to stress is that CSF fistula in this case occur in around at least 6% of the cases. And in the literature states that there is a significant lower recurrence rate when we open the arachnoid in such a strategy. Then we have the anterior decompression strategy that deals with the observation that the association of Chiari 1 and basilar invagination is the most common craniovertebral junction disease in adulthood. In our paper of some years ago, we published a very strange, like an experimental model we had to face with in clinical practice. Dealing with a young boy with basilar invagination with platybasia type A or type 1 according to Goel classification with posterior C1 bifid arc and Chiari malformation. As soon as we performed a huge decompression of odontoid anterior arc of C1 and all, I underline all the clivus up to the synchondrosis with the sphenoid bone, we had a disappearance of Chiari and clinical restoration of the patient. Nevertheless, in the following months, surprisingly, both the odontoid and the clivus regrowth, reproposing the posterior cranial fossa crowding, and also Chiari malformation, in this case, according to Atul Gaur, formation as a result of crowding of posterior cranial fossa, reproduce all the clinical and neuroradiological condition. Very interesting experimental model in clinical practice. Then we have to deal with settings with different way. We all know that settings can be classified according to the fact that it could be associated with Chiari malformation or foramen magnum crowding in type 1, or like type 2 without disease at the foramen magnum, so-called idiopathic syringomyelia, type 3 associated with spinal cord tumor, traumatic myelopathy, spinal arachnoiditis, myelomyelacia, and type 4 pure hydromelia. In the literature, when we speak about settings associated to the Chiari type 0 classification, that means syringomyelia without tonsillary ectopia, and we have to decompress posterior cranial fossa because crowding of posterior cranial fossa still is the driving force for these clinical and neuroradiological pattern. And the way to decompress, according to this algorithm, is the well-known syringostomy or internal shunt. We have to remember that the syringomyelia is associated in some cases of Chiari according to a genetic algorithm clearly identified in the past. Then we have Chiari malformation associated with other pathologies like hydrocephalus, tethered cord, and idiopathic intracranial hypotension. This is a very typical case of a cured hydrocephalus. When the shunt works, no problems at all, no Chiari, no syringomyelia. But when we have a malfunction of CSF drainage, we have recurrences of hydrocephalus along with syringomyelia, along with Chiari malformation. And when we cure, we operate, we revision, we do redo surgery of shunt, we cure everything. So to cure hydrocephalus in these cases means to cure Chiari and associated disease. Let's go to the end of this presentation, focalizing another interesting association, Chiari and tethered cord syndrome. We all know that in these cases, posterior cranial fossa has a normal side. So the concept of a crowded posterior cranial fossa doesn't work anymore in this case. All we have to do is to detether the cord. But to detether the cord accordingly to the clinical and the neuroradiological pattern. Nevertheless, there are some different institutions that deal with this topic in a very 100% Chiari malformation management spirit. And this is associated to the fact that this center developed a very interesting and intriguing way to deal with the tethering procedures with both intradural, extradural way to identify the filum terminalis. But the Italian Society of Neurosurgery had official critical position with this way to manage this very special type of Chiari malformation. Then we conclude with a very unusual case of a Chiari malformation or formation, according to Atul, the idiopathic intracranial hypotension. It's a very strange, relatively unknown clinical condition in which we have a low CSF volume rather than a low CSF pressure due to traumatic, old traumatic or chronic traumatic condition producing epidural CSF collection with nerve root or perinerval root collection and the draining in multiple sites the CSF like artificial or post-traumatic internal CSF shunt, which produce a sagging of the brain. And the way to deal with this condition is to be conservative with bed rest, caffeine and fluid restriction, or epidural blood patch, or even if with fibrin glue or blood, or sometime with surgery. Let's remember which are the neuroradiological more frequent findings dealing with this rare and relatively unknown condition. Number one, subdural fluid collection like hygromas, occasionally hematomas, or enhancement of pachymeninges, uniform or diffuse, or engorgement of venous structures, or pituitary hyperemia, or sagging of the brain with a descending cerebellar tonsil, secondary Chiari malformation, and bowing of optic chiasm and flattening of the pons. Conclusion, which is the take-home message of this brief summary of all the surgical armamentarium available in the literature and personal experience. When we deal with the Chiari malformation type 1, with asymptomatic clinical picture, maybe conservative approach is the best. Otherwise, Chiari malformation type 2 is always associated with hydrocephalus or myomeningocele, huge herniation of the content of posterior cranial fossa in the foramen magnum, generally associated with a very eloquent symptomatology. Surgical strategy is strongly recommended. Nevertheless, concluding with the literature, when we deal with the literature data, we have a contradictory position. In this paper of 2009, opening the arachnoid associated to 50%, 48% of recurrency. Nevertheless, in this other experience published on neurosurgery 2012, opening the dura and opening the arachnoid is significantly associated with a lower recurrence rate of neuroradiology and symptomatology. And this is a slide I had taken with my mobile during the beautiful Congress, Consensus Congress hosted by Dr. Laura Valentini in Milan, the same town of Maurizio Fornari, and I took with this camera these slides, which is a very short abstract of this presentation. When we deal with the Chiari associated with the syringomyelia, 100% of agreement of the audience is in favor of bone decompression duroplasty. A watertight closure is strongly advocated in order to avoid CSF leakage, which is the main concern of duroplasty. And to conclude, I'm a reviewer of papers, as you all are. As a reviewer, I think that to review today a paper dealing with Chiari malformation could be absolutely a real challenge. Too many data, many of those contradictory. We have to ask for help to our knowledge, to our experience, and also to the logic of a rational approach. Thank you very much for your attention.
We thank you a lot. Very nice presentation, really. Probably Maurizio can ask questions.
Yes, Massimiliano, just a very simple question. Which is your personal opinion about performing or not duroplasty and entering or not arachnoid layer? In a short way, your personal view of the problem.
Thank you for your beautiful question. This is a still matter of debate, as we have commented. My personal experience is that to open dura, to enlarge, for sure, to enlarge the posterior cranial fossa is the best chance. When I open the dura, I always want to check with the microscope. And by checking, if I see and I recognize some arachnoiditis or thickness of the dura, I'm there. I have this microsurgical armamentarium. I explore. I cut the breeds, the arachnoid hypertrophy, and I try to complete my surgical strategy in the deepness. when I don't see anything that can impress my interpretation, I try to perform a huge, consistent duroplasty. Better if with autologous substitute like fascia lata or a pericranium. Around 80–90% of CSF leakage reduction with autologous closure compared with a Gore-Tex or a cadaveric or a heterolog patch. A main concern is for tonsillar shrinkage. When you deal with the arachnoid in a few seconds, you should be forced or pushed to coagulate from the internal aspect, both the tonsil, in order to improve the surgical results. Nevertheless, we know that there are some risks linked with the possibility to injure the pica artery and also to produce or induce recurrences of arachnoid reaction, since you manipulate in a iatrogenic, cruent manner the local environment. And so probably when you cut the bridge, the arachnoids, we cure a problem, but when you coagulate the tonsilla, you create a new problem. And so just to cut arachnoid should be advisable, my personal opinion.
Yeah. Massimiliano, there are many questions from participants. One question is that if it fails, the decompression for syringomyelia, what is your option? Do you perform a syringo-arachnoid or syringo-pleural or peritoneal shunting?
Good question. Thank you very much. And this is a second topic, still matter of debate. As a matter of fact, to open the syrinx is the cure, obviously, no doubt about that. But we also know that when you open the syrinx, you can have a transient success, which could be completely overcome by natural healing processes. In this way of management, I prefer to put a catheter inside, a C-elastic catheter inside, and to perform a local syringo subarachnoid shunt. Many other options are available, also drainage of syrinx in the pleura or in the peritoneum, but personally I'm not so confident about this strategy, since when you cough or when you have to perform a bowel activity during the day, you can change the local pressure and you can worsen also the local CSF dynamics. I will never forget what happened when I was a resident and I was helping a senior surgeon who put a drainage inside the syrinx, and the other hand of this drainage was put in the fourth ventricle. The day after surgery, the patient was tetraplegic, and it was performed a CAT scan. At that time, there were few MRI devices in Italy, and what popped up was an hydrocephalus. We had under anesthesia before surgery. This was a typical hydrocephalus linked Chiari and Chiari malformation, and we didn't correctly perform the diagnosis before surgery. And so, since we didn't correct hydrocephalus, we couldn't relieve tetraplegic complication in this unlucky patient. So, first of all, to make the right diagnosis, is it a real Chiari 1 or Chiari 2 malformation, or is it a Chiari formation, according to Goel philosophy, due to hydrocephalus? In the second situation, you should avoid to perform a shunt between still active hydrocephalus and the syrinx. Otherwise, you worsen the clinical pattern of the patient.
Another one, do you ever look at the OBEX? It was a historical treatment. There is one question from participants.
I'm sorry, can you...
do you ever look at the OBEX?
OBEX, yeah, OBEX, yeah. A good question. When I explore, and I explore in the deepness of the surgical field, why not check also the OBEX? I do it. I check the OBEX. And just in case I see there is something I don't like, as arachnoid new production arachnoiditis, I try to debride it. Yes, for sure.
What do you think about the craniocervical fixation? Actually, C1, C2 fixation for Chiari malformation.
Yeah.
Do you also apply this technique in certain cases, or you didn't start it yet? As Atul Goel is advising for all cases, as you know.
Yeah, I'm in love with this very original philosophical and scientific, strongly scientific interpretation. I trust in the fact that instability can produce Chiari malformation. Instability acts like a depressing and sucking hydrodynamic phenomenon inside the brain and the craniocervical junction, so producing tonsillar descending reaction we call a Chiari, but is a Chiari formation, not malformation. So two instruments to fix instability is the right cure for this extreme condition. But sometimes, and we have shown that not all the Chiari formations deals with the C1, C2 instability. Sometimes when I have not the proof, of instability, and the proof means a dynamic flexion, extension, lateral bending, craniocapital neuroradiological assessment, when I have not the proof directly or indirectly, like the fluid collection of in the articular facets or other indirect sign of instability, I am a little bit more prudent, and I try to tailor different strategies for different etiology. That's my personal take-home message. Not all the Chiari are produced by the same etiology. We have to identify clearly the etiology and to cure the etiology. For instance, you remember the case of the young patient with hydrocephalus and secondary syrinx and Chiari formation. In that case, to fix C1, C2 is completely unuseful, because the cause is hydrocephalus. As soon as you drain hydrocephalus, you solve the problem. Just shunt it. And also, in some special case associated with tether cord, just untether, and the tonsils rise up. All other cases, I think, that can be studied for instability and eventually operated with instrumentation and fusion technique.
You mean if there is some criteria, stabilization will be an option? Not in all cases. Do you mean that?
Yes, I think that in all cases I have presented in this seminar is not equally effective C1, C2 instrumentation. I'm sure that Atul agree with me when again we speak about hydrocephalus as a primary driving force of syrinx and the Chiari formation or tether cord. I think he agree with him. As I agree with him in all other situations in which C1, C2 fixation should and
in fact, these were the provocative questions for Atul. Yes, I think Maurizio can present the next speaker. Maurizio, are you there? Maurizio has...
Yes, I'm here.
Good. Okay.
Okay, so let's go to the next speaker, Professor Atul Goel. He has been quoted many, many times before he started speaking, so let's hear to his presentation. Okay.
Atul, you can share the screen.
Yeah. You know.
So you have to make him co-host.
Please share your screen.
Yeah, but you know what, Mehmet? I'm not able to. Yeah, now, yes.
Good. It is there.
Okay. Thank you, my dear friends. I see some very old and new friends on the screen, and I'm very happy to talk to you all. And I was listening to the wonderful presentation of my dear friend Max, Professor Massimiliano. And I was reading the questions asked by the various people. And I have a feeling that I will have a lot of difficulty in explaining my concept. But what I intend to do in this presentation is to present to you a new concept called central or axial, atlantoaxial instability. That is my main purpose of this presentation. So as we have seen, Chiari malformation, or I like to call it, as you have seen here, Chiari formation, as Professor Massimiliano also said, I do not like this word malformation. So this is a very common clinical event. Syringomalia is very commonly associated with Chiari malformation, basilar invagination, Chiari malformation, syringomalia, syringobulbia. Now, before I go to my slides, I want you to check on my slides, and I give you one concept, that the posterior fossa is not tight. You see the subarachnoid spaces here, huge subarachnoid spaces in all the cases. I want you to see my slides, okay? So basilar invagination, syringomalia, you see the subarachnoid spaces, it is not tight. Posterior fossa is not tight in 100% cases. Basilar invagination, Chiari malformation, syringomalia is a common clinical triad. This kind of manifest atlantoaxial instability, like atlantodental interval increase, is a relatively uncommon event. See the posterior fossa, not tight. Now there are two situations. One is when there is Chiari malformation associated with basilar invagination, and when there is Chiari malformation without basilar invagination or without any bone malformation at the craniovertebral junction. The question is, are these two entities different? That is one question. The question number two is the treatment different? So before I go further on this, I have to say that basilar invagination with or without Chiari, with or without syringomyelia, are children of the same father, and that father's name is atlantoaxial instability. So they are the same children, same family. As we have heard, Chiari malformation is treated by a huge number of ways. Posterior fossa craniectomy, C1 laminectomy, C2 laminectomy, dural opening, pericranial graft, Gore-Tex graft, metal implantation, small opening, big opening, very big opening. If you read the literature, every neurosurgeon in the world has a different technique. And every neurosurgeon in the world thinks that his technique is the best. The problem is nobody knows exactly why is Chiari malformation. What is Chiari malformation? Everybody knows the treatment, but nobody knows what is Chiari malformation. So let me try to introduce this subject in my own ways and in my experience, which is about 4 decades, about 40 years experience in this subject. As you know, I recently introduced this concept about 8 years ago. Is atlantoaxial instability the cause of Chiari malformation? So this is the title. And is atlantoaxial fixation the treatment? So I had written about 65 patients in the year 2013. And now in the subsequent 7-8 years, my experience is about 400 cases. And I have to tell you, my dear friends, I have no doubt in my mind that atlantoaxial instability is the cause of Chiari malformation. The problem is that atlantoaxial fixation in these conditions is not an easy surgical procedure. We have to learn how to do atlantoaxial fixation. And if you do atlantoaxial fixation, you will see something which I like to call magic. Magic. You have never realized the magic of treatment of Chiari malformation. And I am saying, without doubt, without question, magic. Only one thing is there. You have to learn how to do C1, C2, very solid fixation. You cannot do a flimsy fixation. Is Chiari a formation or is it a malformation? Is it pathological or is it a protective phenomena? I have to say without question, without doubt in my mind, that it is a natural divine formation. It is introduced in its place to protect the neural structures from compression against the bones in the event of potential or manifest atlantoaxial instability. I also want to introduce to you, my dear friends, one fantastic revolution in not only for craniovertebral junction issues, but for degenerative spine, for OPLL, for Hirayama disease, for a range of problems, the concept of central or axial atlantoaxial instability. So please try to understand what I'm trying to say, because I have no doubt. And please, if you have, this is a good forum for us to discuss. The only parameter to identify atlantoaxial instability was this atlantodental interval. If in dynamic images, the atlantodental interval increases, that is the only parameter in the literature for last 50 years to suggest atlantoaxial instability. We had introduced the parameter of facetal listhesis, facet of C1 listhesis over facet of C2 as an additional parameter to determine the presence of atlantoaxial instability. And we had written long time ago that when there is an unstable spine, you have to stabilize and you have to fix. There is no need for decompression, and you will all agree with that. And there is no confusion. When there is such an instability that you see, the treatment is stabilization. There is no need to do any kind of decompression. So the concept that we had introduced is that facetal instability, C1 over C2. So this article of mine, which was published about 15 years ago, was an additional parameter to atlantodental interval instability. And we said that basilar invagination is nothing but C1 over C2 listhesis, like lumbosacral listhesis. You treat basilar invagination like you treat lumbosacral listhesis. So we have talked about it for a long time, that facetal listhesis is the cause of basilar invagination. And when there is facetal listhesis, there is need for treatment by stabilization, and there is no need for decompression. And you will all agree that when there is Chiari malformation and syringomyelia in presence of manifest atlantoaxial instability, in presence of listhesis, nobody in the world will do decompression. Stabilization is the treatment. There is no question about it, and there is no disagreement about it. So when there is basilar invagination with atlantodental interval disturbance, with listhesis, you all agree with me. And there is no confusion that stabilization is the treatment, and there is no need for decompression. So that is one thing which is not in question. I want to introduce to you, my dear friends, another concept, another classification of instability. Now you very carefully see these slides. This is the type 1 dislocation where the facet of atlas is dislocated anteriorly over the facet of axis, and there is atlantodental interval disturbance, there is cord compression, there is facetal listhesis. You see facetal listhesis, and the treatment is atlantoaxial stabilization. You all agree, in presence of atlantoaxial instability, there is no need for decompression, there is need for stabilization. Now you carefully see this slide. Here you see the facet of atlas is behind the facet of axis, behind. There is no problem in atlantodental interval. There is no disturbance here. There is no cord compression. There is no cord compression. In this situation, the whole world today will do foramen magnum decompression. And I am telling you, this treatment of foramen magnum decompression is an absolutely wrong treatment in the presence of such instability. You need to do atlantoaxial stabilization for such huge basilar invagination. Now you see, please see this another one, type 3. When there is Chiari malformation, when there is syringomyelia, when there is no atlantodental interval disturbance, even when there is a facetal alignment, it suggests the presence of an unstable spine, and it suggests the need for atlantoaxial stabilization. There is no need to open the bone or do any decompression. There is no need to do any syringostomy. You see the syringe size has reduced. So this is a controversial thing for you. And I wish I can explain to you and give a clear message to you that all these three entities are unstable, and Chiari malformation is a manifestation of an unstable craniovertebral junction. The only problem is it is a difficult operation. So I have learned over the period of time, I said for about 40 years, my experience in this subject. In the year 1998, we had written this article, which is very highly cited, that basilar invagination is of two types. In one, the odontoid goes up. In the second, the tonsil comes down. So this was my classification in the year 1998, my understanding. And the whole world's understanding was that these are fixed problems. There is no unstable. This is not unstable. This is not unstable. Decompression is the treatment for mouth or nose, and foramen magnum decompression is the treatment. I had mentioned myself in this article, and this classification I had given, which is a very highly cited article, and this classification is also universally accepted classification. In the year 2004, we said that type 1, where the odontoid goes up, is an unstable atlantoaxial joint. And type 2, where the tonsil come down, is a fixed problem and you need to do decompression. So in 2004, we said that these patients need transoral decompression and these patients need foramen magnum decompression. No, these are unstable patients and they need stabilization, and we introduce a beautiful term called craniovertebral junction realignment. So these patients are unstable, these patients are stable in 2004, my concept. And then all of you know this concept of mine, which is quite a popular concept, that there is in this kind of basilar invagination, there is no need to do any decompression. There is a need to do craniovertebral junction realignment. So when there is a basilar invagination, open the joint, distract the facet, and realign the craniovertebral junction. There is no need to remove the odontoid, no need to remove the foramen magnum. Realignment is the treatment. So now we have got several hundred cases of this type where no decompression is done. And if you ask me today, will you ever do transoral surgery in your life? I will say never, never, other than tumors, of course, chordomas and things like that. But for this kind of basilar invagination, transoral surgery in my department has not been done for last 15 years. This is a historical, completely no need. So you please accept this. I know it is difficult. In this article in 2004, I had said myself, first time in the literature, that type B needs, there is a small posterior fossa in the vertical height, in the height, not in the anterolateral and anteroposterior perspective, and decompression is the treatment. And I had said myself that the opening of dura is not necessary in this article in 1998. And I had published this article in quite a long time ago, in 1995. You can see this, that when there is Chiari malformation, you can do an alternative technique of decompression where you open this bone and reverse this bone, and I called it foramen magnotomy. And I was myself doing foramen magnum decompression for several years. I know what is foramen magnum decompression. I know what is syringostomy. I know what is syringostomy shunt. And I have seen these patients. And today I tell you, all these operations are absolutely not necessary. We said that the dura is like a condom, or dura is an expansile structure. It is mother dura matter. It can hug the child, but never compress. So dura matter, there is no need for opening of the dura. This concept, for the first time in the literature, we had mentioned. Now I discuss about this entity of central or axial atlantoaxial instability. I said type 1, where the facet of atlas goes in front and there is atlantodental interval disturbance. That I call type 1. The symptoms in type 1 are acute. Let me go back. Wait. Let me go back to that classification. I want to show you again that classification here. So this is type 1, where there is atlantodental interval disturbance. The symptoms in type 1, now please listen to this carefully. Symptoms in type 1 are acute. Type 2 and type 3, there may not be any atlantodental interval disturbance. May not be. but may be. Type 2 and type 3 are chronic situations, chronic atlantoaxial instability. Acute, chronic. And type 2 and type 3, we said that these two types are called central or axial atlantoaxial instability because there is no atlantodental interval disturbance and there is no compression of the neurals or dural structures by the odontoid. So type 2 and type 3 are chronic, long-standing atlantoaxial instability, which results in syringomyelia and Chiari malformation and a host of other problems, which I will discuss with you. So this entity of central or axial atlantoaxial instability, in my view, is a complete revolution in the field of craniovertebral junction surgery, and not only craniovertebral junction surgery, but cervical degeneration, Hirayama disease, OPLL, and several other problems. So this is published on several occasions. So in central or axial atlantoaxial instability, it is a chronic phenomenon. The instability may be for 15 years, for 20 years, or for the whole life. And when there is chronic atlantoaxial instability, nature plays its games. There are a host of reparative mechanisms, protective mechanisms, God's mechanism, which protect the human being from the effects of an unstable atlantoaxial joint and from the difficulties that can be posed by the odontoid process. In the presence of chronic atlantoaxial instability, there are a host of musculoskeletal alterations like short neck, torticollis, clipple file abnormality, bone fusions, C1 assimilation, C2-3 assimilation, platybasia. A host of musculoskeletal abnormalities can be natural protective mechanisms as a response to central or axial atlantoaxial instability. You do atlantoaxial stabilization, the neck will become long, the neck will become straight, there is a potential for bone fusions to unfuse, and the entire human being, you will give a new and beautiful smile that nobody has ever seen this smile in the lifetime. And in the evening of operation, when you go to see this child or an adult, you will see a different human being. You see this, although there is no smile on this child's face, but you see a long neck, a straight neck in the evening of operation. You see dressing of the traction is still there and the neck is straight. So all these musculoskeletal abnormalities of torticollis, short neck, there is no need for any osteotomy here. There is no need for any kind of bone work. There is no need for any kind of decompression. And you find a beautiful new life, not only the neck, the symptoms of the limbs, hands and legs completely cured, and not cured, completely new life in the evening of operation. You see this long neck, straight neck, all this, you see the dressing is still on and the neck has become long and straight. So there are a host of musculoskeletal problems which are due to atlantoaxial instability, and they get cured very soon. You see this quite a naughty little boy, and I didn't like his hairstyle, so I thought, let me shave him. But he said, sir, please take care of my neck also. So I straightened his neck as well. And you see, there is quite a beautiful smile. This smile is beautiful on the face of the child, much more beautiful in the face of the relatives. They find and they get a new human being in the evening of operation. Bifid anterior and posterior arch, this article of mine says that bifid anterior and posterior arches of atlas are dynamic. You do flexion, it opens. You do extension, it closes. So there is a dynamic kind of process. And bifid is not an embryological problem. It is a natural protective phenomena in the presence of atlantoaxial instability. You see there is a bifid arch of atlas. So when you see bifid, you don't have to do any investigation. Don't do any investigation. When there is a bifid, it means there is atlantoaxial instability. It means there is need for stabilization. Another beautiful concept, cervical fusions. You see multi-level cervical fusion. I say that multi-level cervical fusion are a protective phenomena in response to craniovertebral junction instability. You see multi-level spinal fusions. This is not an embryological problem. This is a reparative procedure. They are natural protective phenomena in the event of atlantoaxial instability, and you need to stabilize the atlantoaxial joint, and you will get remarkable clinical recovery. There is, in this patient, there is also bifid. So bifid arch of atlas, multi-level fusions are indicator of natural protection in the event of atlantoaxial instability, even when there is no compression. You see, there is no compression at all, zero compression. This patient will get a new life after you do atlantoaxial fixation. You see this in extension, in flexion. There is no compression at the craniovertebral junction. Multi-level fusions. You do atlantoaxial stabilization, and this child has got a new life. And this child was a daughter of a very senior press reporter, and this case was reported very heavily in the Indian news. This patient was not able to breathe before operation, and this patient has got a new life. There is no compression. Compression, presence of compression is not the issue. There are reparative mechanisms by nature, and all these short neck, torticollis, bone fusions are all reparative, and they indicate the presence of atlantoaxial instability. So we said that all basilar invaginations are unstable, and all basilar invagination needs stabilization. So you can see from 1998, I have come a long way, and now I say that all these patients need stabilization. And all this work is very heavily published in the literature. I wish you can see my experience in this subject of selective atlantoaxial fixation is more than 2,600 cases, and I had published Group A and Group B treatment by atlantoaxial stabilization. So this kind of basilar invagination, you see, is not a problem. This is not an embryological abnormality. This is a natural phenomena. So basilar invagination as a phenomena is due to atlantoaxial unstable spine. You don't need to do decompression from front or from behind. You need to do atlantoaxial stabilization. That is the treatment. Don't have confusion. Please don't have confusion. And if you have confusion, you should learn the technique. And if you have a problem, you please come and visit me. And not more than 2 weeks, I will make you an expert in this operation. Basilar invagination, you see, it is not an easy operation, such basilar invagination, to open the facet, to open the joint, to remove the cartilage, to introduce bone graft, and to do C1, C2 fixation, not easy. But this is the treatment for all kinds of basilar invagination. So I say, my dear friends, that basilar invagination is a natural protective musculoskeletal response of God, of nature, to protect the human being from atlantoaxial instability. You see such huge basilar invagination. Today, I tell you, the whole world will do foramen magnum decompression, there is a clear-cut presence of an unstable spine, and this patient needs a beautiful operation of atlantoaxial stabilization. And you take my word, and take the word with great humility and great respect for all of you. Please take my word, in the evening of operation, this patient will get a brand new life. So this is, you can sometimes see this kind of facetal, whether you see unstable spine, whether you see facetal abnormality or not, presence of basilar invagination indicates the need for atlantoaxial stabilization. Early in my experience, I used to do occipital fixation. We were the first one to describe occipital screws in the literature. And we used to do on quite a regular basis decompression and fixation. Today, I say that there is no need for occipital fixation at all. There is no need for decompression at all. But if you are not able to do atlantoaxial fixation, this may be a suboptimal operation, but this may be the only option in front of you. This was the editorial I wrote, occipito-cervical fixation, is it necessary? I am saying inclusion of the occipital bone has been completely abandoned in my operation theater for at least 15 years. Basilar invagination and syringomyelia and Chiari malformation are the children of the same father, and that father is atlantoaxial instability. Chronic atlantoaxial instability will lead to musculoskeletal abnormality that are combined, and they are called basilar invagination, and neural abnormality that are called syringomyelia and Chiari formation. They may be present together and they may be present discretely or separately. Whether they are present together or whether they are present separately, they all indicate the presence of an unstable atlantoaxial joint. Syringomyelia is helpful. I heard my dear friend Max talking about syringomyelia and various kinds of shunts. Believe me, with my experience of last 40 years, I have completely abandoned any kind of manipulation of syringomyelia. My concept is, which this paper was published in 1996, syringomyelia is helpful and not harmful. Any kind of manipulation of syrinx is a negative phenomenon. Similarly, Chiari formation is always a response to atlantoaxial instability, even when there is no atlantodental interval disturbance, even when there is no facetal malalignment. This is an indicator of an unstable atlantoaxial joint and an indicator for need for atlantoaxial stabilization. There is no other treatment. Whether there is basilar invagination or not, whether there is syringomyelia or not, whether there is bone fusion here or not, whether there is any kind of other bone abnormality or not, whether there is atlantodental interval disturbance or not, or facetal malalignment or not, atlantoaxial stabilization is the treatment. And now I will show you several cases. You see, there is no atlantodental interval disturbance. There is mild type 2 kind of an unstable atlantoaxial facet. There is quite a bit of syringomyelia. There is Chiari malformation. So you must see the facets. Only fixation, and you see the syrinx has gone, and there is no foramen magnum decompression. And believe me, my dear friends, believe with great humility and respect to all of you, I say, this patient will get a new life in the evening of operation. Whether there is syringomyelia or not, whether there is basilar invagination or not, whether there is assimilation of atlas or not, presence of Chiari malformation and syringomyelia is an indicator of an unstable spine. You do atlantoaxial stabilization, no decompression, syringomyelia disappears. You will ask me how many times syringomyelia disappears. I will say 100% of time if you do a MRI after 1 year, and about 50% of time if you do MRI after 3 months. No question, no question. The need for syringostomy or syringe shunt is an absolutely wrong surgical procedure. No question in my mind. You see huge syringomalia. There is basilar invagination, Chiari malformation. There is not much facetal malalignment. There is not much atlantodental interval disturbance. I do atlantoaxial stabilization. The tonsil goes up. The syrinx reduces. I am telling you whether there is basilar invagination or not, whether there is syringomalia or not, whether syringomalia is there without basilar invagination or Chiari or not, means sometimes only syringomalia can be present, no tonsillar herniation. Sometimes only syringomalia can be present without tonsillar herniation and basilar invagination. They are the children of the same father and mother, and that father is a very beautiful father, atlantoaxial instability. Preoperative images, you see syringomalia, tonsillar herniation, no problem, little bit problem, you see the syrinx has gone. Syrinx gone or not gone is not the issue. Patient, new life, you give a new life. This operation, my dear friends, is not easy. Is not easy, it is difficult. Please learn this technique. Don't say it is bad because you cannot do it. Don't say this concept is rubbish because you cannot do it. Foramen magnum decompression, any resident of neurosurgery can do foramen magnum decompression. Easy operation. This is difficult operation. But we neurosurgeons, all the young neurosurgeons in the audience have come to neurosurgery. They want to do complex things. They want to give new life to the people. You do this operation, you give new life to the patient without any question. Whether there is basilar invagination or not, you see there is no problem here, no problem here. You see I have done a C1, C2 fixation. You see the syrinx has reduced in the immediate postoperative period. Now I have got hundreds of patients like this. Is Chiari a formation or a malformation? I said that tonsillar herniation is like nature's airbag. It protects the neck in event of an accident. And it is a big protective mechanism, and Chiari malformation, you should not directly puncture this airbag. So there, as you know, many questions. Many people asked me several questions. Pediatric people said, no, this is not good. Some people said it works only in Chiari malformation, in basilar invagination. And some people said that Indian human being is different. American human being is different. German human being is different. Means like a different animal. Like Indian human being is like a lion, and an American human being is like a some other kind of animal, not lion, maybe horse. So this was also the responses that I received. If you read this, they said that the Indian human being is a different human being. And these are various kinds of responses. So I produced this paper in Dr. Massimiliano's book, that atlantoaxial fixation is the treatment of Chiari malformation, even when there is no bone malformation in the craniovertebral junction. No bone malformation, atlantoaxial, you see the joint is a problem. No bone malformation, or there is some bone malformation, you see there is, you do a C1, C2 fixation, and you have a syrinx reduced. Whether syrinx reduces or not, that is not the issue, absolutely. The issue is whether the patient improves or not. Absolutely, my dear friends. You get a new human being in the evening of operation, without any question. You see this syringomalia. Don't say that Indian human beings are different. I get very thoroughly irritated by that. Tonsillar herniation, syringomalia. No problem here, no problem here. You see, I think I have shown you this patient already. There is basilar invagination and there is fixation. Syringomalia reduces. You see, there is syringomalia. There is tonsillar herniation, and there is no serious problem here. And you see the syringomalia reduces. There is an atlantoaxial fixation. Recently, I have published my experience with 388 cases in World Neurosurgery. I wish you can read that article, just very recently published. Syringomyelia, Chiari malformation. Do not do this. You see, there is no tight posterior fossa. There is a lot of subarachnoid space. You open the bone, open the dura. Believe me, my dear friends, very, very negative operation. And open the obex and open the arachnoid. I used to do. I have introduced the concept that opening the bone is not, dura is not necessary. I used to do a lot of dural decompression. I introduced the concept that there is a vertical height reduction in cases of Chiari malformation, first time in the literature. Today, I tell you that there is no question of tight posterior fossa. You need to do atlantoaxial stabilization and you give a new human being. You see another case of syringomyelia, no problem here, little bit problem here, and you see there is syrinx reduction. Syringomyelia, tonsillar herniation, fixation, no decompression. Syringomyelia, no decompression. Now I have got 300, I have published 388 cases, and I will give you another very beautiful, beautiful statistics. I produced 388, you read my article. I have written in my article 100% result. I have got 100% improvement in symptom. Can you write this for foramen magnum decompression? Do you have that courage to write? Because when I write 100%, if one patient is not improved, he can produce this in a very, I can be in very serious problem. 100%, can you write it? Chiari malformation, syringomyelia, you see the syrinx has reduced. When there is basilar invagination, of course, there is atlantoaxial stabilization, syrinx reduced. This is a difficult operation. There is no question about it. And you have to learn this technique beautifully. And there are various other secondary manifestations in the form of short neck, short head, short spine, short body in the event, which are all protective. I also introduced a new term called external syrinx. There can be syringomyelia inside the cord, syringomyelia outside the cord, syringobulbia inside the bulb, outside the bulb. And these can be common, and these are new terms. This water is life. Water can never go wrong. Water can be inside the cord, outside the cord, inside the medulla, outside the medulla, inside with association of tonsillar herniation. They are all natural protective maneuvering. When this patient, a very elaborate engineer, and he had been shunted and he had undergone several times foramen magnum decompression, shunt, EVDs, tethering, detethering, 13 operations he underwent, and then I did atlantoaxial fixation. I gave this poor man from a village, a very intelligent man, a new life, and the syringomyelia has disappeared. This was the boy. There was a tube in the nose. There was a catheter here. There was tubes everywhere in his body. He could not even sit with his neck straight. And immediately in the post-operative period, although he has catheter here, but this catheter was removed very soon, and this person has got a new life. I have got his video here, but it is I am not sure if you can really appreciate these things in the very post-operative period when he was being taken home, and from a very remote village, a poor man, but a rich man, he was then able to walk. And he was not able to do anything here. There are some things which are preoperative also here. You see this guy, I cannot show you how he's talking because he's talking in Indian language, but he could do nothing. So failed foramen magnum decompression, what you will do? Nobody knows. You will open some more dura, you will open some more bone, you will do some more CSF shunting. Please don't do it. Please try to understand. I am not trying to talk these things on a high pedestal or with ego and pride, because you are students of neurosurgery. You are students of our great subject. We need to understand. When I wrote this paper, many pediatric neurosurgeons said, no, it doesn't work in pediatric patient. I wrote this article in 33 patients, and if you read 100% improvement in various symptoms in a child, you see there is no problem here. There is some problem here. And I did C1, C2 fixation, and there is a reduction in the And these are the two pictures when he came for a follow-up after I think 1 or 2 months. He could run beautifully. I gave this child a new life. I gave this mother a new smile, and I gave this a new birth to this human being. And there are several children in my series. There is no question about the treatment. Idiopathic syrinx, nobody in the world knows what is the treatment. I am saying syringomyelia is the child of the same father, whether it is present in association with the tonsil. I saw one slide of Dr. Massimiliano, and I will like to ask him what he will like to do. You do shunt, this patient is finished. You do any kind of hydrocephalus shunting, EVD, finish. This patient is dead. Don't even see this patient. You give him new life, and you see the syrinx is gone. And I reported 9 cases long time ago. Now I have got several cases with idiopathic syrinx. This is the treatment. They don't have confusion in your mind. Kyphoscoliosis can be associated with syringomyelia. Very rapidly, I will show you, is another child of the same father, and that father is here. So this father of atlantoaxial central instability has got several children all over the world, and that another, this kyphoscoliosis is this. You see, the whole world will produce 200 screws here and 1 kilometer of rod on this side, 1 kilometer of rod this side, right up to the neck and right up to this part. But this patient does not need this kind of treatment. He needs stabilization. And you see, there is this turn and this turn in the very image. This after 2 or 3 months of surgery, this is no instrumentation here. Same father was treated. And this, you see this, during operation, you have MEP improvement. So, and this central or axial, atlantoaxial instability is a concept. Is a revolution in our field of neurosurgery. You see, when there is this patient, there is no compression, no problem, but there is a presence of bifid. This patient has a central atlantoaxial instability. You give this beautiful smile to this child and beautiful smile to this doctor, and this is possible if you understand. You don't talk to me on a high pedestal. Indians are different and I am different and your group of patients is different. Please don't talk in that language. Please talk in a language which is common and which is scientific. Can foramen and magnum decompression become historical? Absolutely, yes. Thank you very much.
Thank you, Atul. Very contradictory views and very nice presentation, really. There are many questions. I will ask one of them. Actually, what is your surgical strategy if there is a high riding vertebral artery in one side?
Yeah. If there is high riding vertebral artery, I recently wrote one beautiful article that you can treat.
Okay.
If there is a high riding vertebral artery, sorry, can you unshare my screen, MEHMET?
Yeah.
Okay. Yes. Sorry.
Only. Okay, good.
If there is a high riding vertebral artery, you have to deal with it. Mm-hmm. You have to save it. You have to protect it. And there are various ways to protect high riding vertebral artery. And there are several articles of mine which discuss how to protect the high riding vertebral artery. That is not a excuse not to do C1, C2 fixation.
Can I make a question?
Yeah, please.
Well, I have 3 technical questions. First one is the importance of traction for basilar imagination, pre-op traction. The second one is
let me answer this question.
Okay.
I use traction only during the operation. I don't give pre-operative traction for basilar invagination. That is the answer to your question. Okay, number 2.
Number 2 is Do you use intraoperative image-guided surgery, which means O-arm navigation?
There is no need. I have navigation in my department. I used to do some navigation earlier, but now you see I have got an experience for several years, as you know, of doing this C1, C2 fixation. I do not do, but navigation is a good tool. You must, for the people who are not very familiar, they must use it. I will recommend.
I would recommend it mostly for even a resident can perform C1, C2 during the night. But the third one, which is, in my opinion, very important, is how do you perform fusion?
My fusion is 3-step surgery. I described 1988, I described C1, C2 fixation. My technique has 3 steps. Open the joint, remove the C1, C2 joint, remove the articular cartilage, introduce bone graft in the joint, then do fixation. If you do not do these 3 steps, you have not done a good operation. If you have to do a good operation, you have to do 3 steps. Open the joint, remove the cartilage, introduce bone graft inside the joint, and then do fixation.
Okay, thank you very much.
Thank you.
There is one question telling that if atlantodental interval is normal and there is no obvious instability, don't you think C1, C2 fixation is an over-surgery? Because fixation will decrease the neck movement. In some cases, suboccipital craniectomy is enough for treatment. In such a case, why should we prefer fixation? And
now, you know what? Let me, Mehmet, answer this question. If you are asking this question to me after my lecture of at least half an hour, it means you have not understood what I am saying. You are talking just because you want to be strong. And you are talking, you know, you want to say that, no, I'm not trying to talk on high pedestal. I'm saying that there is a concept of central instability. You please try to understand. If there is no atlantodental interval, even then there is an unstable spine. Please try to understand. If you do not understand, please go ahead and do decompression. I'm not stopping anybody.
I mean, but in the question, there is with C1, C2 fixation, there may be some restriction of the movements.
No restriction. You see, the person is restricted. You know, in Chiari malformation, you can have breathing disturbance. You can have sound. You can have voice disturbance. You can have sleep apnea. You can have continuous pain in the neck. You have myelopathy pain. You have symptoms in the hands. In advanced cases, there may be symptoms in the legs. I am saying the person will get a new life in the evening of operation with minimal, if at all, if you are saying minimal restriction of neck, which nobody has ever questioned me. Nobody.
In related question, do you stabilize C1, C2 in neutral position or in specific angle?
See, in basilar invagination group A, where the odontoid goes up, I like to reduce that dislocation. But in most of these cases, it is not a radiological manifestation. It is unstable spine. So 3 steps of operation, which I have said: open the joint, distract the facet, remove the cartilage, introduce bone graft, then fix. And there is no need to maneuver to reduce in central instability.
I can probably ask Maximiliano to make some comments.
Mehmet, you should unmute his microphone.
Sorry, Massimiliano.
Okay, thank you. Do you hear me right now?
Right.
Yes.
Sure, I'm sorry for that. I was speaking, but I was convinced to be effective for audio. transmission. Thank you so much, Atul, for your beautiful, outstanding, challenging, and proud presentation, because you had the courage to move against old-fashioned trend, and this old-fashioned trend is completely associated to the need to demonstrate instability in order to stabilize some unstable functional spine unit. This is the old-fashioned primary statement and suggestion to demonstrate instability in order to program, to plan, and to perform stabilization and fusion. In your experience, you presume that instability is working under the Chiari and syrinx and pathology. And I love the way to call children and fathers. And I love the way to define C1, C2 vertical instability like transatlantic C1, C2 instability. I'm convinced for a big part of your presentation that C1, C2 instability is the background for Chiari and syrinx. Nevertheless, I underline, nevertheless, not 100% of Chiari syrinx, in my personal experience and opinion, are completely depending from C1, C2 instability. I still remember the hydrocephalus as driving force, the tether cord as driving force of some forms of Chiari and syrinx. And no doubt at all that if you don't treat hydrocephalus and fix C1, C2, at least in my opinion, you have not any guarantee that such a surgery should solve the problem. Otherwise, if you treat hydrocephalus in hydrocephalus linked Chiari malformation syrinx, or you detether the cord in some special of tether cord linked Chiari malformation, you don't solve the problem. As well as if you don't rule out the diagnosis of Chiari malformation from the one of intracranial hypotension, and you fix C1, C2 when you deal with an hypotension syndromes, according to the neuroradiological pattern I have demonstrated, you perform a bronch surgery with, I think, very uncertain results. And I'm sure that when my friend Atul deal with intracranial hypotension, according to the neuroradiological pattern I have shown, he doesn't indicate the need of C1, C2 instrumentation infusion operation for such a Chiari formation as a sagging brain complication due to intracranial hypotension. These are special cases that go out of the circle of the paternity of the father and the children. Sometimes there are other biological relationship within father and children. No, we are not always children of the same father, as we know, and so we have to underline that not 100% of a situation are related to only one etiology. As in brain tumor surgery, as in vascular surgery, as in the traumatic surgery, we cannot identify only one pattern of pathology derivation. And so in this very intriguing and challenging malformation clinical pattern, we have to identify correctly the disease and its cause. And I congratulate Atul for having introduced a new concept, very difficult, but very fascinating and very reliable and scientific valid new concept to deal with Chiari and settings.
Now, Mehmet, can I answer this question? Can I answer his comments, Massimiliano's comments? See, the issue is, Massimiliano,
Yes.
I am not saying when there is tumor and Chiari, tethered cord and Chiari, hydrocephalus and Chiari, that you should do C1, C2 fixation. I don't know this entity of, intracranial hypotension. I don't know this because, I always have hypotension in my head all the time. I don't know what is this. I don't understand this complex intracranial hypotension as a cause of Chiari. I don't know. But this Chiari is this is a regular Chiari without any other associated problems in the spine or trauma-related settings. If you ask me trauma-related settings, tumor-related settings, those are different. I'm talking of general Chiari, general settings, general problem.
Yes, I was interpreting your concept of Chiari formation. Because Chiari formation is a consequence of tonsillar herniation in some situation. And I completely agree with you that Chiari malformation doesn't exist, and Chiari formation as a result of a compensatory mechanism, as a response of a pathophysiological mechanism is very convincing. And we can have inflating of hairback in different situations during a car accident, or just when we manipulate the car in a wrong manner, or as a simple accident. In three different situations, this mechanism can pop up, and the problem is to identify the mechanism with the airbag inflate and to treat it or to prevent in some situation. And I think that your field is completely correct.
Mehmet.
Hocam mikrofonunuz kapalı.
We can go to Dr. Solanki's lecture now.
Yes, I think that I don't see Mehmet, but first, finally, I want to give my personal compliment to Professor Goel. It was really something outstanding, and everybody realized it. So thank you very much. And now I will like to give him to let Professor Girish Solanki give his presentation. And he's talking about the different options in pediatric patients. So welcome, Professor Solanki.
Hello, Maurizio, thank you so much. First of all, of course, I would like to thank Professor ZILEL for giving me the opportunity to share the podium on the symposium on Chiari malformations, along with greats like Atul Goel and Massimiliano Visocci. So I'm truly honored to be here. Before I start my presentation, while I'm sharing the screen, what I'd like to do is also to pay credit to my predecessors. Are you able to see my screen?
Yes, it's okay.
Excellent. So I'd like to, first of all, before I start, to say a great thank you to those before me, like Professor Tony Hockley. And of course, I learned so much from Atul, MEHMET, Massimo, and everybody else that I meet, because Chiari, as you heard Massimiliano say this, and also Atul, is not simple, it's not straightforward, it's not what you see, and also there are changing concepts, and pediatrics in particular, where there is a wide array of different types of Chiari malformations, provides a much bigger tapestry than in adults. And I hope for your forgiveness, because I will be introducing topics that may not be very immediately clear or known, or may even be controversial. And if that happens, then I say sorry in advance. I'm very happy to answer any questions at the end. I'm going to go a little bit fast because gratefully Massimiliano and Atul have talked about a significant number of items in Chiari that I don't particularly have to go into great detail. So some of my slides I will just flash through, and I don't want you to be upset as well, because I don't want to patronize anybody. Now, I work at the Children's Hospital in Birmingham. This is a very old hospital, more than 150 years old, and a lot of great people have worked here with an interest in Chiari malformations. One particular one was Bernard Williams, who talked about the dissociation, craniospinal dissociation theory for development of syringomyelia and Chiari, and many others. And of course, Tony Hockley, my predecessor, who also developed the initial decompression on the skull for craniosynostosis patients, also worked here. I think everybody will agree that what a Chiari malformation is, as initially described, is that is a paraxial mesodermal insufficiency occurring after the closure of the neural folds takes place. The primary factor in the formation of the hindbrain hernia is being, in most instances, a small posterior fossa due to underdeveloped occipital bone. And that's the cases that the Chiari 1 cases that we normally treat. But of course, they are not all of them. And the main objective of surgical treatment is directed to restore the normal CSF dynamics at the craniovertebral junction. If you look at the natural history of Chiari, and I have talked about this in the past, I think the largest study going over a period of 3.5 years was about 20 years ago, John Hopkins. And what they did is they looked at 22,591 MRI scans looking for children who had Chiari malformations. And what they found is that 175 patients had Chiari malformations, of which about 21 to 25 patients, about 14% of the patients actually had asymptomatic hernias. And these hernias, when asymptomatic, were not associated with either syringomyelia or osseous anomalies in these patients. And the average tonsillar hernia was 11 millimeters. So this is what we call the asymptomatic natural history. But when I looked at this study in detail, I found that in this group of patients, only 6 were children under 18, so of less significance to pediatrics. The relationship that they identified in these patients was that if the hernia increases, then the cisterna magna becomes small. And after 10 millimeters, from 10 to 15, there is a reduction in the cisterna magna. And after 15 millimeters, there is often absence of the cisterna magna. So there was a positive correspondence between these two anatomical features. But for us, I think the more important study was that from Professor De Rocco's team in Rome, where they looked at 22 patients, and half of those were actually asymptomatic. They were incidental findings of Chiari, but the ones that actually had symptomatic presentations, 22% progressed to clinical worsening. And 14% of this group then progressed to surgery. So clearly there is some progression. And this again, goes against the definition of a malformation, because malformations, congenital malformations, don't progress. If you are born with something which is congenital, you have it and you have to treat it. But congenital malformations don't progress to get worse. So we decided to look at this. And of course, 20-something years ago, when I started pediatric neurosurgery, I was ignorant in most aspects of care in hindbrain hernia, Chiari malformations. And I started looking at the literature. I started doing my own studies to try to understand this better. And what I discovered is that the presentations that already exist were short follow-ups, 2.5 to 3 years, in those patients, progression is very small, less than 10% progression. And there was no evidence of regression. And then later, in the last sort of 10 years, 2 large studies, Professor De Rocco study in 2008 and our current study, which we presented in 2013, demonstrated a much larger progression and also some regression because our follow-up was longer. So it was more than 5 years. And in these patients, there is definitely greater progression between 10 to 14%, but there is also 3 to 5% regression, spontaneous regression of the Chiari. So the literature kind of tells us that if you are treating Chiari malformations, you have to follow them for at least 5 years to know where they're going. Not all of them require immediate surgery, but there is a rapid deterioration in these patients, which occurs within the first 2 years in those that usually have either CSF flow problem, ventriculomegaly, or some skull-base anomaly. So what is the pattern of progression and severity in a Chiari 1 in children? What is the fate of a Chiari, first of all? We found that out. Some are symptomatic, 3 to 5 regress, 9 to 14% will progress, and the vast majority will remain stable. Do they progress equally? Of course not. The simple Chiaris, without ventriculomegaly, craniosynostosis, CSF signal loss, they will progress slowly. But the complex Chiaris, those are the ones that are expected to progress rapidly and will end up requiring surgery. And in fact, there is multiple publications in the literature that associate hernia with syringomyelia between 30 to 75% of the cases. And what is the mechanism of progression? Well, a lot of theories, because this is not very well understood, how a hindbrain hernia, for example, will develop a syrinx or a scoliosis. The commonest and most well accepted will be Bernard Williams' postulation of a craniospinal pressure dissociation or Gardner's suggested CSF pulsation as pathological drive to progression of hindbrain hernia and syringomyelia. And when does it become a surgical problem? When do neurosurgeons will consider treating a Chiari? So in pediatrics, a huge survey of the International Society of Pediatric Neurosurgery carried out some 20 years ago identified that most neurosurgeons, pediatric neurosurgeons, will consider a tonsillar descent of 12 millimeters with loss of CSF at the craniocervical junction and of course appearance of a syrinx as parameters to consider surgery. Can any Chiari be treated by a foramen magnum decompression? And I think that's an interesting question because the gold standard for treatment has been the performance of foramen magnum decompression. I've put this slide up because I thought that Professor Massimiliano did a very good job in identifying what the consensus amongst neurosurgeons is in terms of how do you go about managing Chiari and so on. So thank you for, I've borrowed the slide from your presentation. I think this is quite helpful. But the important thing here is, do you do foramen magnum decompression for everybody? And I think the answer is no. And you heard Professor Goel talk about the cervical instability requiring a different approach in patients with Chiari. And I will also tell you that patients with craniocephalic mismatch, such as in craniosynostosis or with deformation of the back of the skull, they will also require different treatments. So the first thing I will say is that along with Massimiliano and Professor Goel, I would also say that Chiari malformation is a term that should be discontinued and should be called deformation. Deformation of the cerebellar tonsils, not malformation, because malformation implies that the child was born with a hindbrain hernia from birth, and we know this is not true. We know that this progresses over a period of 5 years or 10 years, and therefore it can't be a malformation, it is a deformation. And evidence coming out from fetal surgery in myelomeningocele has also shown that even Chiari 2, which was considered a different entity, is also a mechanical progressive herniation. And if you operate on a child and repair the myelomeningocele before birth, the hindbrain hernia regresses in nearly 100% of the cases. So we know that these are progressive mechanical malformation, deformations of the cerebellar tonsils because something is pushing it down, or there is a leak down which is sucking or creating a sump effect, which is dragging the posterior fossa CNS downwards into the spine. So we call that supratentorial crowding. And what that means is that there is a pressure coming from above the tent, pushing down onto a very small posterior fossa and dragging the contents of the posterior fossa into the foramen magnum. And that will be very much part of what I will intend to talk at this presentation. So there are, and it's just not just one item, but you all know that Chiari malformations, as we call them, so I prefer to call them hindbrain hernias. So you all know that hindbrain hernias are associated with ventriculomegaly, craniosynostosis, basilar invagination, craniocervical instability, scoliosis. These are very well recognized now. Of course, not all of them will have all of these features, but these are the known associations. And interestingly, these are also very much the same associations for syringomyelia. In addition to that, of course, syringomyelia can also be associated with tethered cord, lipomas, split cord malformations. That means that there is something down, pulling the spinal cord downwards and causing dysfunction of the spinal cord and formation of a syrinx. So ventriculomegaly, first of all. So how does ventriculomegaly, how is ventriculomegaly associated with the Chiari? Does ventriculomegaly cause the Chiari? And there is some evidence that the presence of pressure within the ventricles causes increased downward push, like a piston drive effect, pushing the tentorial cerebelli and the cerebellum downwards. And of course, this then will obliterate the CSF flow at the craniocervical junction with loss of buoyancy and further descent of the tonsils and impaction. So that could be one mechanism for worsening of Chiari and syrinx. But it could also be said that as the Chiari blocks the foramen of Monro and Luschka and stops CSF flowing at the craniocervical junction, that in itself could then cause the ventriculomegaly above it. So there is, of course, two possibilities here. And I think in the end, both mechanisms play a role in development of the hindbrain hernia. Now, of course, don't take my word for it, but there's multiple publications now coming out from Professor De Rocco's team, from my good friend Conor Malucci in Liverpool. And all of these are indicating that if you just do an ETV for a patient with ventriculomegaly and Chiari, 94% will remain shunt-free. And 83% with the syrinx will show improvement and resolution of the syrinx following the ETV. So this is a minimal procedure for which there is a resultant improvement, not only in the hindbrain hernia regression, but also deflation of the syrinx. There's a large study coming out of China as well, showing an 80% success rate. So as we move forward, there is more and more treatments that are coming, which are resulting in improvement in both the hindbrain hernia and the syrinx. So we ourselves did a study in our hospital looking at the effects of ETV. And when we looked at all of our patients that had undergone ETVs, identified those that had a Chiari and syringomyelia, we found at the time that we presented this study, there were only 139 ETVs and 10 patients. But the number of those patients now has increased to 12. And what we found is that these patients had a 90% success rate in deflation of the syrinx and regression of the Chiari by a simple ETV. And there were a number of associated conditions with it, but you can see that isolated Chiari was one of the significant set of patients that we had done ETV on, more than 50%. Okay, so this is ventriculomegaly. Then move on to syringomyelia. So what are the factors associated with syringomyelia when you have a hindbrain hernia? Again, there's lots of theories, poorly understood. I talked about this. 30 to 75% of Chiaris can have a syrinx. But what we started finding is there's very specific radiological features that seem to be associated with the syrinx in children. And not only that, we then did a wider study looking at not just the radiological, of course, this is very well known to you, and you can see what happens here, the CSF flow at craniocervical junction, and then what happens, there is compaction of the small posterior fossa, the angle of the tent drops down, everything gets blocked, and no CSF will no longer move, and then a syrinx will develop. So, and Menezes nearly 30 years ago reminded us that patients who develop syringomyelia with hindbrain hernia often have skull base anomalies, up to 50%. So again, this is what Professor Goel has been telling us, that this is a significant group of patients with the Chiari and syringomyelia, and the craniocervical junction anomalies need attention and treatment. So what are these things? So what we found is that in our series with syringomyelia and hindbrain hernia, craniocephalic mismatch was prominent. We had craniocervical compression, craniospinal pressure differential, and also some cases with restriction of spinal cord ascent, either by tethered cord, lipomas, and so on. So a number of factors associated with syringomyelia. And when we did our review, we found a number of anatomical angles in the posterior fossa, which were predictive of development of a syrinx when a Chiari occurs. The most important one really was the loss of CSF signal at the foramen magnum, which was significantly associated with syringomyelia. Now, a lot of those measurements are not done in a clinical setting because it does take some time to do them, even though they're quite useful. It would require radiologists to measure them. But what is helpful, for example, are the clinical variables. And our statistician very clearly identified that a child who has 100 months of age, that is 8 years and 4 months, has a tonsillar hernia more than 12 millimeters, has a sagittal diameter of the foramen magnum ratio with the posterior fossa height more than 0.6, and the ratio of the clival angle to the foramen magnum clival angle of less than 0.8 is highly predictive for development of syrinx. And this is a very strong correlation of variables using a principal component analysis for prediction of syrinx. So we know that some patients will progress, and we also know that which patients will then end up getting a syrinx. And then we started putting together all this knowledge that we were acquiring. So we knew that Chiari and syrinx formation were associated with a small posterior fossa, and our experience with patients with craniosynostosis told us that those patients are more likely to develop what we call supratentorial crowding, and that will then push the small posterior fossa contents down into the spine, leading to obstruction of the foramen magnum, and then subsequent development of the syrinx. And clearly, to all of you, if you see a patient who has got such severe raised intracranial pressure with the copper beaten appearance, with this honeycomb appearance, then it will be very easy for you to understand that in a deformed skull, a typical craniocephalic mismatch like in Klebat shadow deformity, that this child, of course, will get a hindbrain hernia, and that will then result in a syrinx. So that concept, I think, is very easily understood. So what if there is less of a compression? And this is cases, for example, if you look at the one in the middle here, you can see the flattening of the back of the head there, same thing there. And the thing that you see is that the contents above the tentorium, which is occipital lobe, are actually now lying behind the cerebellum, and the cerebellum has been pushed forward, and you can see a worse situation here with herniation of the hindbrain hernia on the image on the right-hand side. Okay, so you can see the CSF around, hardly any CSF, and less CSF. So again, it goes back to the features we identified, which we call supratentorial crowding, which is a steep angle of the tent, a flattening of the occipital bone, venous engorgement, cervicomedullary kink, standing up cerebellum, occipital lobe posterior to the cerebellum. So all of these features are very typical. When you look at an MRI like that, you know that this patient's got craniocephalic mismatch. The brain is smaller than the skull volume. Some of it is going to herniate, and a lot of it has to do with skull-based anomalies, as I will explain later. Now look at this. If I make a graphic the pictorial demonstration of what is happening, you can see that the line that goes from the posterior clinoid to the inion contains about 1/3 of the cerebellum above it. But if you look at the ones with the hindbrain hernia, most of the cerebellum is below that line. And not only that, on the picture on the left-hand side, the occipital lobe is above the line. On the others, the picture now is well below the line, as you can see here. So there is a reduction in the posterior fossa volume because of supratentorial crowding of supratentorial structures, which are now lying in a diminutive posterior fossa. And only one thing can happen is that you're going to get a hernia. And the hernia, of course, will then start progressively compressing on the brainstem and create what we call the foramen magnum compression syndrome with vertical oscillopsia, cranial nerve palsy, swallowing difficulties, and so on and so forth. So this progressive tonsillar herniation doesn't happen in a day. It happens over a period of time. And what it does is that it further reduces the posterior fossa volume, causes angular changes of the skull base, including the development of platybasia, because a lot of these patients have actually a failure of the occipital somite. So the proatlas is diminutive, and the clivus, instead of being elongated, is short and stubby. So you lose a few millimeters of the base of the skull because the tip of the lowermost tip of the clivus actually incorporates in the odontoid tip, which becomes dolichoid. So the size of the posterior fossa is affected by a skull-based anomaly and becomes smaller. And of course, all of this will lead to other things. Now, what we discovered when looking at the foramen magnum is that in Chiari 1 and Chiari 2, the foramen magnum sagittal and transverse diameters, as well as the surface area, are bigger, are larger in Chiari 1 and Chiari 2. And Professor Goel also alluded that in a number of his patients, you have adequate CSF in the cisterna magna, and the posterior fossa doesn't look too compressed at the foramen magnum. So we have found the same thing, that a lot of these patients actually have a very large foramen magnum. Even though the posterior fossa may be small, the foramen magnum is wide open because the herniation may have already occurred before the ossification of the posterior, the opistheon. So this, this was the next step in our evolution in terms of knowledge, that now we have supratentorial explanation, a posterior fossa explanation, foramen magnum explanation, and then finally we got to the spinal explanation. And what we essentially are saying is that Chiari 1 and Chiari 2 are hernias. They are not malformations, they are hernias. And those hernias require an increase in the intracranial contents, a small relative cranium, and the presence of an incompetent hernial orifice for syringomyelia then to happen, which is the effect of essentially what we call a strangulated hernia. Now, a few years ago, I was very kindly invited by Professor Goel to give a talk on craniovertebral malformations in children during the International Congress held in Rio de Janeiro on craniovertebral junction. And what I talked about was my very early experience in pediatrics on what of the skull-based anomalies are associated with Chiari and syringomyelia. And again, I would mention this just in passing because Professor Goel has already talked a lot about this. Occipital somite 4 is what we're looking at. It leads to the development of proatlas, and all of the skull-based anomalies that we are interested in come from the proatlas. Okay, so this is essentially what you need to remember. And then the atlas assimilation is the commonest abnormality that you'd find, and the type 3 is the one that you most likely you're going to be operating on. Type 1, of course, is just the fusion of the anterior arch of C1 to the clivus. Type 2 is also the presence of a posterior C2, C3 laminar fusion, and type 3 is when there is an association of instability with this. Now, if you think about atlantoaxial instability, group 1 is what I just told you, is the type 3 atlantoaxial instability. The type 3 assimilation of atlas. Group 2 is there's no atlas assimilation, but there is odontoid hypoplasia or maldevelopment, which you often see in things like Down syndrome and other cases like mucopolysaccharidosis and so on. And group 3 is when there is neither odontoid hypoplasia or maldevelopment, no atlas assimilation, but there is rotatory subluxation or a degree of central instability, which you cannot very easily identify. So all of these aspects of atlantoaxial instability need to be taken into consideration when you plan treatment for Chiari and syringomyelia. You know very much what atlantoaxial instability is. I'm not going to spend too much time with this, but what I wanted to show you is that you need to consider the various types of instability. Horizontal, vertical, particularly for us, rotatory, okay? So when you look at this, you have to think of, although we look at two-dimensional images, the instability is actually a three-dimensional process. And I'm always reminded about what Professor Goel said, that atlantoaxial dislocation instability is the primary cause of all types of basilar invagination. And I would agree with that. And I want to show you what we have discovered in our patients about what happens during basilar invagination. Here's a normal appearance with normal anterior atlantodense, posterior atlantodense measurements. But then as time goes by, as the horizontal instability happens, the anterior atlantodense interval increases. And finally, what happens is the head, the weight of the head starts sending the C1 arch down onto C2. And when that happens, you would have to ask the question, how does a lateral mass of C2 slide upwards against the lateral mass of C1? And if you think of this, look at this picture here, that's C2 and that's C1, that's the joint. So how do you get basilar invagination where C2 goes up? The only way this can happen is when there is a widening of the lateral masses of C1, hypoplasia of the lateral masses of C1, or rotation of the lateral mass of C1, such that it will allow the lateral masses of C2 to slide upwards. Okay, so if you look again pictorially, this is the normal appearance. This is now the widening of the C1 lateral masses. They start falling sideways. And you can see now that there is an angulation of the C1, C2 joint. That's becoming more obtuse, nearly vertical. When that happens, C2 can slide inside of C1. Okay, and this is when it completely slides. At this point, there is now compaction of the C0, C1 joint. The C1, C2 joints become nearly vertical, and the dents will now be lying either just below the foramen magnum or through it. And this is a picture that shows you the situation, a sagittal view. You can see this is the lateral mass of C1, but actually the lateral mass of C2, which should have been down here, is lying behind and above. And Professor Goel showed a lot of these images today. I could clearly see what was going on there. And of course, this is the pathophysiological progression of these patients from group B to group A, and the facet instability that occurs with them, where not only these patients will show either anterior facetal instability or posterior facetal instability, but may have central instability, and that will cause significant cord compression from the front or from behind, particularly if there is a syrinx and a Chiari present as well. This is a particular case that we had, a child that presented with snoring and all the other features. You can see the Chiari in the back, the very significant herniation, type A basilar invagination. This is the CT scan showing the nearly vertical facet joints that start occurring in these patients as C2 slides through the middle. You see the widening of the C1 lateral masses, so C2 slips up between the widening of the C1 lateral masses, and there is a vertical arrangement of the C1, C2 joint that allows the slipping inside. So instead of calling it medial facetal instability, instead of calling it central, we could call it a medial facetal instability because it's going through the midline. And again, you can see how this is now a vertical joint when the joint should have been horizontal, and that would have prevented the platybasia, the basilar invagination. Again, more pictures. So I operated on this patient, and I did what Professor Goel has been recommending, to distract C2 from C1, to open the C1, C2 joint, jam the C1, C2 joint with bone graft, and this is the pre and post-op appearance. You can see here the C1 was completely through, C2 was completely through the foramen magnum, and this is after distraction, joint jamming, and C1, C2 fixation. Is a child with a simulation of atlas, as you can see. So this is pre-op appearance on the right-hand side, with the post-op appearance on the left-hand side, a significant improvement with regression of the initial features, and the child is much improved with improving myelopathy. So this is definitely something that I've included in my armamentarium for treatment of Chiari malformations. And to me now, the mechanism in pediatrics for Chiari and syringomyelia is more obvious, and it includes, in the first instance, at the very top, ventriculomegaly causing raised intracranial pressure, supratentorial crowding, craniocephalic mismatch. Then if you look at craniosynostosis patients, they have got a craniocephalic mismatch, and that will lead to formation of a hindbrain hernia through herniation. And finally, basilar invagination, craniocervical junction anomalies, small posterior fossa, craniocephalic mismatch. All of these will create a downward push, stretching, Chiari, and final pathway, syringomyelia. On the other side, if you have children who have got tethered cord, that can cause a caudal pool without a Chiari and lead to syringomyelia. So this was our identification of the multiple pathologies involved in Chiari and syringomyelia, and we decided, therefore, to start looking at changing concepts. They were already beginning to appear. We, of course, changed our concept way back in 2003, but others started operating and saying, well, if you, for example, have craniocephalic mismatch, don't bother to do foramen magnum decompression. Just treatment for the craniosynostosis will reverse the Chiari. Larger paper coming out from Finland supported our posterior cranial vault distraction surgery with similar results. Another one from Paris suggesting that posterior cranial vault distraction is an efficacious technique to enlarge the posterior skull vault. And a number of other papers, and you'll find them in the literature. So the idea really is that we should consider something that does not require us to open the dura, because we know that opening the dura is the biggest problem. And you heard from Massimiliano, in adults, foramen magnum decompression by using a variety of techniques, and Professor Goel alluded to this as well, is the standard gold standard treatment for treatment of Chiari. But I put to you that you now have heard what happens in children and the various other alternative treatments. And I want you to consider also the problems of foramen magnum decompression. If you do too extensive resection, you get further herniation. If you open the dura, then you get the complications of CSF leak. And a number of people have now reported the recurrence rate. And Massimiliano showed a nice slides talking about the recurrence in Chiari surgery, which can be nearly between 25 to 50%. Kleklamp also talked about what happens in these patients. My colleagues in Oxford talked about problems after Chiari 1 malformation, including recurrent subdural hygromas. My colleagues in Liverpool reported that they had, following a simple Chiari 1 foramen magnum decompression that they developed, these children had the chance of developing iatrogenic hydrocephalus. And a similar study from Ireland also indicated that foramen magnum decompression is not to be underestimated, that they not only had increasing incidence of hydrocephalus in 18.5% of the patients, but also significant mortality and morbidity. So for this reason, we started doing posterior calvarial augmentation, which is the expansion of the skull to increase the supratentorial volume without opening the dura. The procedure is based on simple fact that these patients have a small back of the head, small posterior fossa, small flattening of the back, and they don't have to be craniofacial patients. Chiari 1 patients have very similar appearances on the MRI scan, and the intention is that we expand the back of the head, and by doing that, we create the space available for the brain to expand into a normal intracranial volume, thereby relieving the herniation in the foramen magnum and allowing CSF flow, which will then lead to deflation of the syrinx. Here is an example. This is a raised intracranial pressure before decompression. You can see the diploic veins, collateral circulation. After we do a posterior calvarial release, the pressure goes down, and that creates the space. Initially, we only did a posterior release up to 2003. Since then, we've been doing augmentations and distractions. I'm going to go quickly on this because it's not as important what we do, but it's important why we do it. This is the surgical technique. I'm just passing through. I've shown this in the past. Is opening the posterior calvarial space and then fixing it with plates. We now have, as I mentioned in my previous talks, nearly 40 patients with this technique, but we have another 75 patients with using distraction. So we've crossed the 100 number with no mortality, very little morbidity, and most of these patients have regression of their hindbrain hernia and syrinx. So I'm just going to jump these pictures now. I think you've seen the technique. It's been published. The distraction requires basically pulling the skull back like that over a period of time. And you can see what happens. A flat back becomes a normal back. And it's this change in shape that results in more space for the hindbrain hernia to regress. This is the results of so 75% of the patients that had distraction who had the syrinx had the regression of the syrinx or deflation of the syrinx. Finally, I just wanted to tell you about the last technique that we use, which is patients who have either lipomas, have a tethered cord and a hollow cord syrinx. When we do a resection of the lipoma or treatment of a neural tube defect, what we identified is that these patients also have a deflation of their syrinxes or regression of the hindbrain hernia. So this is what we call the caudal pool that results in improvement in their syrinx as well. So just to finalize now, what I want to tell you is again to remind you that Chiari 1 and Chiari 2 are not malformations, they are hernias. The tonsils are deformed, not malformed, and is due to an increase in intracranial contents or a smaller relative cranium in the presence of incompetent hernial orifice. And syringomyelia is the effect of hernial strangulation. You saw the algorithm of how it happens. Now, if we turn it around, then we can say that if you have ventriculomegaly, an ETV, and monitor. If you have a Chiari with craniosynostosis, that means craniocephalic mismatch, do a posterior calvarial augmentation. If you have scoliosis requiring correction, do a calvarial augmentation first, and often the scoliosis recovers and does not require a long segment fixation. If you have basilar invagination or craniocervical junction anomalies, then consider a C1, C2 fixation. If that fails, then you can do something else. And finally, if you have a isolated some form of distal tethered cord, this also can improve by surgery on them. And I just wanted to bring to your attention that patients who have had foramen magnum decompression and have then failed with further progression of their syrinx were offered posterior cavity augmentation with improvement. So here's an example of a patient who had two procedures of foramen magnum decompression with resection of the tonsils, and the patient continued to deteriorate and developed the hollow cord syrinx. After failing on 2 attempts and demonstrating adequate cisternomagna, adequate flow at the craniocervical junction, we carried out, this is after the second operation, we carried out a posterior cavity augmentation. And soon as we carried out the posterior cavity augmentation, within 3 months, the syrinx deflated and the hindbrain hernia, CSF at the craniocervical junction improved. So I'm going to conclude now by saying that hindbrain hernias should not be called Chiari malformations anymore. They are deformations of the cerebellar tonsils. They are usually caused, particularly in children, by supratentorial crowding, but they also can be associated with ventriculomegaly, which can be treated by simple ETV in the first instance. The small posterior fossa is often associated in nearly 50% of the cases by skull-base anomalies, and those require treatment first before anything else. The syringomyelia can be caused by what we call the blockage of the foramen magnum or a caudal traction of the spinal cord. And this is a summary of what I've just told you, that this is how we treat our patients. If they have ventriculomegaly, we would first treat by ETV. If they have craniocephalic mismatch, we treat by posterior cavity augmentation. If they have instability, we carry out a fixation first or distraction of the invagination. And we don't treat the syrinx directly, we treat the Chiari, and that usually results in improvement. So I'm going to stop here and allow time for questions. Thank you very much.
Okay, I don't know if MEHMET came back, but I want to thank you for your fantastic presentation. And my comment is that after Goel presentation, we had only a single father. Now we have 2 fathers, because when we are talking about body-on imagination, you do completely agree with Goel, but you introduced a different concept beside the concept by Goel, which was just instability, C1C2 instability, which is supratentorial crowding plus smaller posterior fossa plus some craniocephalic mismatch. So we have 2 different theories in some way. They can meet somewhere, but by one side, we are looking at the Chiari malformation or deformation as a problem which arises from C1, C2. By the other side, we look at this problem from the top, from something which is crowding and increasing the pressure on top of the posterior fossa. I don't want to make any comment about it, but I will ask to Massimiliano to give his comment and possibly suggestion to how we can really unify these 2 different theories, and also to the other speakers. Massimiliano, can you hear me? Unfortunately,
Massimiliano, please.
Okay.
Okay,
I'm
sorry.
Okay.
Thank you, Maurizio, for your beautiful question. I think that partially I try to answer this question.
No, it's a difficult question, of course.
Yeah, absolutely. In the first part of this webinar, I think that there are many fathers. Thanks to Goel to introduce the concept of fathership, and also your comment about 2 different fathers, the same of mine of some minutes ago. Many children, many features, many clinical and neuroradiological patterns for different etiologies. Number 1, to identify etiology. Number 2, to tailor therapy. No doubt at all that the Goel philosophy is effective for those kinds of Chiari and syrinx association with
Massimiliano, we are completely out of time. So try to be short. I'm sorry to interrupt you, because I would like also to have a comment from both Girish and Goel, if it's still there. Okay, try
Yes.
to be short.
And
Many people are leaving now. Okay.
Yes. And I agree also with Girish, who identify a different etiology for a similar feature. So the answer is not what seems similar is similar. So the answer is to identify the right pattern for right surgery.
Okay, thanks a lot. Goel, are you still there?
Yeah, yes,
Your
yes.
comment?
No comments, no comments. Wonderful presentations. I enjoyed to give this presentation, and I enjoyed hearing from both my friends Girish and from Massimiliano. As you know, the subject of Chiari malformation is quite a complex subject, and it has been studied for more than 100 years. We all look for answers. We all look for various kinds of discussion, and this discussion will have to go on, and ultimately I hope we reach some kind of consensus. Thank you very much for allowing me.
Thank you very much. Atul and Girish, do you want to give us a final sentence?
I think, as I said, I learned from my predecessors, from masters in surgery like Atul, Massimiliano, MEHMET, as I mentioned, Professor Hockley and others. So the important thing for me was a journey of discovery. And what I've done is I've done my own studies. So I am fairly confident about the findings, because just like others, you have to actually do it to, first of all, don't just poo-poo things. As Professor Goel says, some things are difficult. You have to do it. Then you make your own mind about these things. And I learned the technique of Professor Goel only 5 years ago. I've been doing it for a while, but I could say that I'm confident in doing it only in the last 5 years. And in those 5 years, we have used a methodological system to allow us to identify the children that would be suitable for this surgery. And we have done now 6 cases of children with Chiari and syringomyelia using the Goel approach. Of the 6 children, 1 has failed, and it's probably because of my surgical technique. And that child is now gone for posterior calvarial augmentation. But the others are stable or have got better. So I know that there is validity in what Professor Goel has demonstrated in pediatrics as well. And I'm very keen to see the long-term results on that. And with the other things, it's a collaborative effort around the world. So none of that is my discovery. So the ETV in ventriculomegaly is being done by everybody around the world now in pediatrics. Very simple operation, and it resolves. Posterior calvary augmentation, we started it in 2003. We've got now 15, 16 years of experience and more than 100 cases. It's safe.
Okay. So I think that we can close now. I want to thank everybody and the speaker for being really
and it works
fantastic.
For those patients with craniocephalic mismatch. Thank you. It was
Thank
great.
you very much to everybody. It has been really fantastic webinar. Thank you very much.
Thank you.
Thank you.
Thank you to everybody.
Thank everybody for participating this this nice webinar.
Okay.
See you again.
See you, you came back.
Bye.
Okay. Bye.
Bye.
Okay, bye.